Hey everyone, it's Sarah, registered nurse, RN.com, and today we're going to talk about autonomic dysreflexia. And after you get done watching this YouTube video, don't forget to access the free quiz that will test you on this condition. So let's get started. What is autonomic dysreflexia, also referred to as AD or autonomic hyperreflexia? Well, to help us really understand this condition, let's break down its name. And we're going to use the word hyperreflexia. So hyper means excessive or exaggerated. And reflex is talking about a reflex response. So autonomic hyperreflexia or dysreflexia is an exaggerated reflex response by the autonomic nervous system. And we're specifically talking about the sympathetic nervous system, which is our fight or flight system. Now, the autonomic nervous system is divided into two parts. You have the sympathetic nervous system. Also, you have the parasympathetic nervous system, which is that rest and digest. And in this condition, this sympathetic nervous system reflex is really unopposed by this parasympathetic nervous system, which is going to lead to severe hypertension. Now, why is it occurring? What's triggering it? Well, it occurs due to some type of irritating stimulus that is occurring below the site of the spinal cord injury. Now, not all patients who have a spinal cord injury are at a high risk for autonomic dysreflexia. Only patients who've had a T6 or higher injury are at the highest risk of developing AD. And whenever they do get this irritating stimulus, it can trigger that reflex response by our sympathetic nervous system and lead to hypertension, as I already pointed out. And if this is uncontrolled, it can lead to a stroke or a seizure and can be fatal. So it is a medical emergency. And as the nurse, we play a very important role in preventing AD, detecting it, and acting on it appropriately, which we're going to cover in our nursing interventions. Now, what causes AD? What causes an irritating stimulus below that site of injury? Well, there's really three big causes that can lead to this that I want you to remember. And how I like to remember this is the three big B's. So the most common cause of autonomic dysreflexia is a bladder issue, like a urinary tract infection or a full distended bladder. Another cause is a bowel problem, like hardened stool in the rectum where you have impaction. And another B I want you to remember is breakdown of skin, where that person has maybe they're developing a pressure injury, also called a pressure ulcer, they have a cut in their skin, they have a skin infection, or maybe an ingrown toenail. It's some type of irritating stimulus occurring below that site of injury. Now, anything can really cause AD if it's providing that stimulation. Some miscellaneous causes could be like menstruation in your female patient, the birthing process, or even sexual intercourse. Now let's break down the pathophysiology of autonomic dysreflexia. So we know that we have an autonomic nervous system issue, specifically an exaggerated reflex response by the sympathetic nervous system. And our autonomic nervous system controls our involuntary functions that me and you can't do consciously. So you have the autonomic nervous system, and it's divided into two branches, sympathetic and parasympathetic. And these systems work beautifully together, but they oppose each other, and we want them opposing each other. Because if one kicks in, we want the other to be able to come in and maintain homeostasis of our body. Because for instance, if we are constantly stimulating our sympathetic nervous system, that fight or flight, the body is going to wear out, you're going to stroke out, or you're going to have a seizure and die. So we really need that parasympathetic nervous system to come in and say, hey, let's calm down a little bit so they can work together. Now, our sympathetic nervous system, as I pointed out, is a fight or flight. So whenever you are perceiving something that's dangerous or you have an irritating stimulus in your body, your sympathetic nervous system says, hey, we got to do something about it. So it causes your body to react. And that will cause your brain to take care of the issue, whether it's running away from that bear or it's as simple as emptying your bladder. It will take care of that. And how the sympathetic nervous system reacts to something is it causes vasoconstriction. So it's going to narrow your vessels down. When we cause vasoconstriction, that increases blood pressure. So I want you to remember that concept. Vasoconstriction, high blood pressure, because that's one of the huge problems with this condition. Also, it stimulates your sweat glands, so you start to sweat. It causes bronchodilation, so you can breathe better. Increases your heart rate, and it dilates your pupils so you can see better. Now, your parasympathetic nervous system is going to do the opposite of the sympathetic, because remember, this system wants us to rest, digest, chill, relax, and reproduce. And what it's going to do is it's going to cause vasodilation, where vessels are going to widen, and that's going to drop your blood pressure. It's also going to decrease your heart rate by stimulating the vagus nerve. And I want you to remember these two functions of the parasympathetic system, because here in a moment, whenever we go into how AD really transpires, it's going to make a lot more sense about what's occurring above the site of injury versus what's occurring below the site of injury. Also, your parasympathetic nervous system causes increased salivation, it causes bronchoconstriction, and it constricts your pupils. So as you can see, these systems, they work beautifully together in opposing each other to keep things in check and in balance in your body. But it can only do this successfully if it has a healthy, intact spinal cord. So these messages can be sent and the body can react appropriately. So if we sever this connection with like a spinal cord injury at T6 or higher, we're going to create this disconnection between the parasympathetic and the sympathetic system. Now let's talk about what's occurring during autonomic dysreflexia. So we've already established that in order for this condition to occur, we have to have that irritating stimulus that's occurring below the site of injury. And usually the most common cause is something to deal with the bladder. So here we have a full bladder. It is sending that irritating stimulus to our body, which is causing our nerves to send impulses that, hey, something's wrong. Well, normally this would go to the brain and the brain would say, oh, we have a full bladder, and you would go and empty it. But here, there's no communication. Remember, it's being blocked due to the spinal cord injury. So instead, this exaggerated sympathetic reflex response occurs. And this is not just some normal sympathetic response that you have. This is excessive, exaggerated. And what it's going to do is it's going to cause vasoconstriction of the vessels below the site of injury. Because remember, we don't have a connection between really our upper and lower. It's been severed. So whenever we have this vasoconstriction, these vessels are going to narrow together. This is going to increase our overall blood pressure. And how do you think the lower body is going to look compared to the upper body since we have vasoconstriction going on down here? Well, it's going to be pale, cool, and clammy because we're really constricting blood flow to non-vital organs. Now, because of this elevated blood pressure going on, the body will sense it, specifically these baroreceptors. It doesn't know what's going on, that there's an issue down here. All it knows is that, hey, this blood pressure is high, and these baroreceptors in the carotid sinus and the aorta say, hey, we can't maintain this. So we are going to have to cause the parasympathetic system to kick in so we can bring this blood pressure down. Now, whenever parasympathetic activity is stimulated, it will cause vasodilation, because remember, that's one of the things it does. So our vessels are going to widen in hopes of decreasing blood pressure. Now, they're widening up here, but this parasympathetic nervous system impulses can't be sent down here because it's being blocked. So we have vasodilation up here and vasoconstriction down here. Now, how do you think the patient's going to look on the upper part of their body above that site of injury? Well, they're going to be flushed because you have vasodilation. It's increasing blood flow to the skin. In addition, this parasympathetic activity is going to try to slow the heart rate down, because remember, that was one of the things it does. And so it'll stimulate that vagus nerve to do that, and we'll get bradycardia, because nothing's really wrong with the heart rate to begin with. So if we lower it even more, we can get that heart rate less than 60. And all that is attempts by your body to decrease this blood pressure, but it's not going to work. This compensatory mechanism is not effective because we have vasoconstriction down here, which is really taking over. This pressure is going to stay high and elevated until we can remove this irritating response and treat the patient appropriately. So with all that pathophysiology in mind, now let's look at the signs and symptoms and some things you need to watch out for as a nurse to detect if your patient is experiencing AD. So one thing is a throbbing, pounding headache. They may report this, and if they do, you want to immediately check their blood pressure, and this is from the elevated blood pressure. Another thing is hypertension, and this is where the systolic is 20 to 40 millimeters of mercury higher than their baseline. Now, patients with a T6 or higher injury, their systolic tends to run about 90 to 110. So let's say that their blood pressure, their baseline is about 106/78. Well, you take it and it's 146/92. Well, that meets the criteria. They're 40 millimeters of mercury higher in their systolic. So you want to watch out for that, look at that, because in normal patients, if we see 146/92, we're thinking, that's a little bit high, nothing too major. But with patients who have a spinal cord injury, you want to be worried about that. Also, as we pointed out, you'll see flushing on the area above the spinal cord injury, and below it, it will be pale, cool, and clammy. And again, that's due to the vasoconstriction below the injury and the vasodilation above the injury. Also, bradycardia, where that heart rate is less than 60. They may experience goosebumps, sweating, dilated pupils, have a stuffy nose, and anxiety. Now let's wrap up this lecture and let's talk about nursing interventions. So what are you going to do for this patient with autonomic dysreflexia? Well, remember PDA. As a nurse, we play a huge role in prevention, detection, and action. So first, prevention. You want to think of the 3 big B's as I discussed at the beginning of this lecture. And what were they again? Bladder, bowel, and breakdown of skin. These are usually the most common causes of autonomic dysreflexia, but again, remember anything below that site of injury that causes some type of irritating stimulus can lead to this. So let's talk about bladder first. Again, it's the most common cause. So as a nurse, you want to make sure your patient's bladder is being emptied properly. You want to assess that urinary output. Make sure it's at least 30 cc's per hour. Also, perform regular bladder scans to make sure that the bladder is not retaining urine, and these are really easy to do. You can get, most units have these devices. You take it to the bedside, use ultrasound jelly and this probe, and you scan the bladder, and the machine will tell you how much urine is in the bladder. Also, you want to make sure you're taking measures to prevent urinary tract infections. And a lot of these patients have Foley catheters, so you want to make sure that you are providing proper Foley care, assessing the color of the urine, making sure that a urinary tract infection isn't presenting. Also, if they do have a Foley catheter, is it draining properly? Because these things are so easy to get kinked or blocked. So always be assessing that tubing of the Foley catheter regularly. And if it's blocked, irrigation can be used to remove the blockage. And let's say that for some reason the patient doesn't have a catheter and you need to drain the bladder. Well, before you go in there and insert a Foley catheter, this in itself is going to cause an irritating stimulus. You want to use some type of anesthetic jelly, whatever the doctor orders, to help decrease that stimulation of that sympathetic reflex response. Another cause is a bowel issue, and usually this is from impacted stool, where a large amount of hard stool gets stuck in the rectum, and this can provide an irritating stimulus. So as a nurse, you want to assess for bowel sounds, palpate the abdomen. Do you feel distension, any hard areas? Also assess their last bowel movement. That's really important. When did they last pass stool? And you want to check for impaction if needed. So what do you do if they're impacted? Well, prior to actually removing the stool, just like the Foley, before you go in, have to do something that is invasive like that, you would want to use an anesthetic jelly to help numb the area and decrease that sympathetic reflex response. And then breakdown of skin. So as a nurse, you want to make sure you're looking at your patient. You're removing any binding devices or clothing that can be irritating to the skin, especially below that site of injury. Repositioning the patient at least every 2 hours, which is a minimum. Assessing their skin regularly, looking it over. Are there any infections? Looking at their toenails, looking at anything that's breaking down. And protecting them from any pressure injury or getting hurt, because again, any cut, bruises, or anything can cause that irritating stimulus. Then we have detection and action. So again, just to recap, who's the most at risk for autonomic dysreflexia? It's those patients with T6 or higher injuries. And with these patients, you always want to assess and monitor their blood pressure. And we hit on this in signs and symptoms. And an elevation of a systolic 20 to 40 millimeters of mercury, more than baseline, is something you definitely want to investigate. And if your patient reports they have a headache, you definitely immediately want to check their blood pressure, see what their baseline is and how much has it elevated. And you want to assess for those signs and symptoms of autonomic dysreflexia that we just covered. That's part of just detecting if this is starting to occur, looking at how does it look above the site of injury, below it, and what to do if these signs and symptoms present, which tie us into our action part, because AD is a medical emergency. So if you're in the hospital, you want to call a rapid response and get help immediately, because you're going to need help moving this patient, because we want to position the patient at 90 degrees with their legs lowered. Now, what this does is that this is going to cause gravity to allow blood to pull down those legs and help decrease the blood pressure. Also, you're going to be assessing that blood pressure every 2 to 5 minutes. Remove any binding devices or clothing. And then you want to investigate what causes, what are the 3 big B's that we have to watch out for that tend to cause autonomic dysreflexia, and you want to correct it. We want to remove that irritating stimulus. So what are we going to start with? The most common. So you'll start with the bladder. Is it full? Is there urinary tract infection? What's going on? If that's not the issue, look at the bowel. Do we have impaction? And then proceed to the skin. Now, sometimes we do all that and the blood pressure is still elevated. That's when medications will need to be used to treat the autonomic dysreflexia. Some medications sometimes ordered by physicians are like nitro paste, and on your screen you see a picture that's like an example of what nitro paste looks like, and it's a topical application that goes on the skin. Now, some things you want to remember about nitro paste or any type of nitro medications is that you do not want to administer them to a patient if they have taken a phosphodiesterase inhibitor in the past 24 hours. This is like sildenafil or tadalafil, which is Viagra and Cialis. This can cause hypotension. And another medication that can be ordered is like nifedipine, which would be ordered like an immediate release route, like sublingual, so it can work fast. And it's part of the calcium channel blocker family. Okay, so that wraps up this lecture over autonomic dysreflexia. Thank you so much for watching. Don't forget to take the free quiz and to subscribe to our channel for more videos.